Welcome to everybody and thank you so much for coming along. First of all, I'd like to begin with acknowledging the traditional owners of the land on which we meet today, which is the Wurundjeri, and it's part of the Kulin Nation. And I'd also like to pay respect and to the elders past and present, and also any Aboriginal or Torres Strait Islanders who are in the room. I also would like to just acknowledge Joyce Bonello, who was one of our net nurse team, who suddenly passed away on the 12th of November. So we just would like to make sure that and say that Joyce rests in peace, and she's greatly missed. So we've got an action-packed evening for you. First of all, we've got Professor Michael, and then we've got Associate Professor Grace Kong. Then we've got Cherie Chian, who is an endocrinologist. We've got Erin, who is the senior dietitian here at Peter Mac. Kate, who is the net nurse consultant here at Peter Mac, and then you have to put up with me for a little bit at the end of it. And we'll also do a question and answer time, so hold on to your questions. Unfortunately, Professor Michael has to leave a little bit earlier, so at the end of his presentation, if you have any pressing questions that you'd like to ask him, then please do. We'll have a few minutes that we'll allocate to that time. Otherwise, we can either take them on notice, or we've got, I think, a depth of experience that we'll be able to answer things. So Professor Michael is a consultant medical oncologist, gastrointestinal and neuroendocrine oncology, medical oncology, and the trial lead for upper gastrointestinal tumour stream. And he is also the co-chair of ENET's Centre of Excellence here at Peter Mac. Professor Michael is a consultant gastroenterologist and neuroendocrine medical oncologist. He's co-chair of the Peter Mac ENET Centre of Excellence and medical trial leader of the upper GI tumour stream. He graduated from Monash University, completed his medical oncology training at the Peter Mac, followed by a 2-year fellowship at the Princess Margaret Hospital in Ontario in Canada. So Professor Michael is going to give us an update on medical oncology and clinical trials, and he's going to give us a bit of an overview beforehand of what medical oncology is and NETs.
Thank you.
That's it. And there is a clicker if you need it.
Fantastic. Good. So, hi. Thank you for the invitation to speak. What I'll do is just talk about a bit of the medical oncology treatment of NETs, with a bit of introduction about NETs at the start. Talk about how we think about how we treat patients based upon the disease biology, and then also talk about the clinical trials that we're running at Peter Mac, and also a bit of medical oncology trials overseas, just to give a flavour of what's happening overseas as well. So, I mean, as you know, NETs occurs in almost any organ of the body, mainly from the esophagus down to the anus and all the other associated organs in between. And it's most of what we see here mainly from what's called gastropancreatic NETs, mainly from the stomach, pancreas, duodenum, small bowel, also the rectum and colon, and also the appendix. And also, we also see a large number of lung NETs as well. Doesn't seem to be working. And this is just some population data from the US. It's actually showing you that if you look at the panel on your left, showing you that orange dotted line, and on the bottom is the years, and we're going from about 1970s to about 2012, and you can see that the incidence of NETs has increased. It's increased about 6 times over about 4 decades. And we've done similar analysis in Victoria and in Queensland, and again we're showing that same increase in incidence over time. And we have a way of classifying NETs. When we take a specimen from a biopsy or remove a primary lesion, we then look at it underneath the microscope. And by looking at the way that the cells look underneath the microscope, whether they're well differentiated, look like very normal cells, or very nasty cells, poorly differentiated. And we also look at markers like the Ki67, which tells us how quickly they're dividing. We classify NETs in terms of well differentiated grade 1 to grade 3 and poorly differentiated. and really based upon our decisions on treatment and how we treat based upon that classification, and also the disease extent as well, and disease volume. And as you're probably aware, a lot of subspecialties are involved in the treatment of NET patients, including medical oncologists, surgeons, nuclear medicine doctors, dietitians, endocrinologists, nursing staff. We've also got geneticists involved, cardiologists, cardiac surgeons. So a lot of people are involved to have that specialty, multidisciplinary specialty involvement. And you'll hear from other specialties and how they manage such patients. So what I'll talk about is the well-differentiated grade 1 to grade 3 NETs and the poorly differentiated cohort as well. We generally use guidelines, internationally accepted guidelines. We're part of an ENET Centre of Excellence, so we use the ENET guidelines. And we really think about, do these tumours have somatostatin receptors on their surface, yes or no? Are the patients no symptoms and low volume disease, we can just watch and wait or use somatostatin analogues? Are the patients symptomatic from their disease or hormone syndromes, and therefore do we need to think about somatostatin agents, or do we need to think about biological agents or chemotherapy or radioactive therapy? And you hear a bit about those as well. And so when do we treat? Well, there's a cohort of patients that we just watch and wait because their disease is low volume, it's growing very slowly, the patients are asymptomatic. And we can watch these patients for a prolonged period of time without doing anything. But there are other groups of patients that have large volume disease, their symptoms because of their disease or their hormones, and the disease is progressing over time on CT or PET scans, and therefore we need to treat. And these are the medical treatments that we use, including the hormonal therapy, the somatostatin analogues, lanreotide, octreotide. Teletristat's an agent we use in some patients whose hormones we can't control with these hormone agents. There's biological agents. In Australia, we have access to everolimus or sunitinib. They're only approved for pancreatic NETs. Internationally, there's cabozantinib, which is probably coming out in the next year or so, and surufatinib as well, which is developed in China and being tested in Europeans. And then there's chemotherapy. And Dr. Kong will talk to you about PRRT as well. So what about somatostatin receptor therapy? Well, we use octreotide or lanreotide, and we use it in most patients with functional hormonal carcinoid syndrome. And Dr. Chian will talk to you about that. And we know from multiple studies that the hormonal therapy does control the carcinoid flushing and carcinoid diarrhea in over 70% of patients. And also if you have pancreatic hormones being secreted by your tumour, it also decreases those hormones as well. But we also know that these agents reduce the growth of these tumours as well, from 2 large studies using octreotide or lanreotide showing you that they do delay the growth of the tumour. If you look at these survival curves, where the proportion of survival is on the vertical axis and the time is on the horizontal axis, you see that both octreotide and lanreotide both delay growth. And we also have now these biological agents, and we know much more about the biology of these diseases now. They have a lot of receptors on their surface, which if they're stimulated, cause cell growth or hormone production. And we also know the internal machinery of the cell, which causes tumour growth and tumour spread. So we have a lot of agents now which we can specifically target different receptors or different machinery within the cell to delay tumour growth, including everolimus, sunitinib, cabozantinib, etc. And there's very good data to show that in the case of everolimus, we can use that in pancreatic NETs together with sunitinib. We certainly do that in a lot of our patients. And also everolimus is good in small bowel NETs, lung NETs, etc. as well. And there's a Chinese agent called surufatinib, which targets a whole variety of different receptors on the surface of the tumour. And that has shown very good activity on the panel on your right in patients with pancreatic NETs, and also on your panel on your, left is pancreatic NETs, panel on the right is the small bowel NETs, delaying the tumour growth. This agent hasn't reached Western shores yet. There are current trials testing it in Western populations. More recently, in the last 3 months, there's a large phase 3 or randomised trial of a drug called cabozantinib, which is another inhibitor of multiple different pathways versus placebo. And this was tested in patients with NETs had been previously very heavily treated with hormonal therapy, chemotherapy, PRRT as well. And they found, if you look at the yellow curves, that cabozantinib in both pancreatic NETs and small bowel NETs does delay tumour growth. It improves the progression-free survival, delays the progression of these tumours in patients receiving cabozantinib compared to placebo. And it's an agent produced by Ipsen, and they're now in the process of trying to apply to the government to get PBS listing. And I'm sure it will have a place in our management. And when do you use these biological agents? Well, generally we, as I said, the everolimus and sunitinib is used in pancreatic NETs. We certainly do use the everolimus in lung NETs as well, and small bowel NETs. We generally use it in patients with progressive disease that have moderate to large volume. Some cases we use it in first-line therapy if hormonal therapy or PRT is not suitable, or as subsequent therapy if they've progressed on that treatment. When do we use chemotherapy? In some patients who have more aggressive disease or very large volume disease, we'll step in with chemotherapy as first line or as second or subsequent lines of treatment. We often use a combination of oral chemotherapy drugs such as capecitabine or temozolomide. And there's other agents where we use a combination of intravenous and oral chemotherapy, such as capecitabine with oxaliplatin, for example. So that's the grade 1 and grade 2 NETs. What about the grade 3 NETs, well-differentiated grade 3 NETs? Well, we use somatostatin analogues in some of these patients if they're very frail and we don't think they can tolerate chemotherapy. We do use PRRT, and Dr. Con will talk about that. And we also use chemotherapy in those patients as well, and often we use capecitabine temozolomide. Let's change now to the very aggressive grade 3 neuroendocrine carcinomas. These are very aggressive in patients and not treated like the grade 1 and grade 2. There's now been recent guidelines produced by ENETS, which we follow from last year. And what they do recommend compared to the other NETs is that we should look at the genetics, the genes of these tumours, because sometimes in these genes there are targets, there are abnormal genes where there's other drugs we can use, for example, that we can use in patients with colon cancer and lung cancer. So it's worthwhile doing genetic analysis on these tumours, and we try and do that for all our patients. Generally with patients with neuroendocrine carcinoma, we use chemotherapy up front, and it's usually platinum etoposide, but the overall survival in half the patients is very poor. It's only about 11 to 12 months. And when you use second-line therapy after they progress, there's also very poor results as well. So we obviously need to improve our treatment in that set of patients. Immunotherapy has also been used in neuroendocrine tumours. As you know, immunotherapy has shown a lot of publicity in lung cancer and in kidney cancer and melanoma. And we use a combination of either you can use PD-1 drugs such as pembrolizumab or nivolumab, or CTLA-4 drugs such as ipilimumab, for example. And single-agent immunotherapy doesn't have much activity in neuroendocrine tumours. So we've actually combined the two drugs together. And in this Australian trial led by Oliver Klein at the Austin, and we were involved in the trial as well, they combined nivolumab with ipilimumab. And overall we found it was very reasonably tolerated. And when we looked at our NET patients, we found that approximately a third to a half of our patients responded quite nicely to this treatment. But in particular, those patients with lung NETs and those patients with more aggressive pancreatic NETs. And we've seen very prolonged responses with that as well. So what about clinical trials at Peter Mac? And we've opened up a number of trials and completed a number of trials. The first one we're about to open very shortly is called the STOPNET trial, where patients have had PRRT. And the question is, what do you do about the somatostatin analogues? Most of these patients with PRRT have progressed on somatostatin analogues, they then have PRT, but there's always some thinking perhaps SSAs now may have a role in perhaps stabilising the disease after PRT. And there is some conflicting literature about that. So this trial is randomising patients after PRT to somatostatin analogues versus observation. So it's going to be a trial which is going to be run in Australia and in Canada and New Zealand as well. We're also looking at different formulations of the somatostatin analogues. As you know, for those of you who have had the injections, they're very difficult to give. It's a difficult injection. It causes large bumps in people's buttocks, which are quite uncomfortable, sort of like golf balls. So now they're coming up with different formulations. One formulation is the CAM 2029 formulation. So it's like actually a jelly. So it's a very easy injection. You don't have to mix it up too hard. Just go straight into the buttock and just distributes like a jelly within the buttock and does cause no lumps. So there's now comparisons between that and standard formulation octreotide LAR to see whether it's better tolerated and has better control. We've also been involved in looking at agents, biological agents such as everolimus. Is it better to use everolimus compared to PRT in patients with grade 2, grade 3 NETs? And this is a randomised trial called the COMPOSE trial, which are about probably complete recruitment, probably the first quarter of next year, involving approximately 500 patients across several centres across the world. And it'll give us very important information about the role of PRT in the high grade 2, grade 3 NETs, and whether everolimus has really a role, or other types of chemotherapy. And we're also continuing the work with Oliver Klein, again with immunotherapy combinations in patients with high-grade NETs as well. And getting towards a more aggressive end of the spectrum, the neuroendocrine carcinomas, we do have now this current phase 1 trial of this agent called ABVV706. It's an antibody which is attached to a chemotherapy drug. And we know that a lot of these high-grade neuroendocrine tumours and lung neuroendocrine tumours have receptors on their surface which the antibody binds to. So the antibody then binds to the tumour cell gobbles it up, releases the chemotherapy to kill the tumour cell. And they're combining this agent with standard chemotherapy and also immunotherapy as well to see whether we get better response rates and better tolerance. So it's a current phase 1 trial we're involved in at Peter Mac and across other centres across the world as well. What about international studies of interest? I actually went through these. You can go through, look at clinical trial searches through National Cancer Institute of the US. It's actually very few trials coming in at the moment. The majority are looking at biological agents, and this is the Carbo-NEN trial, which is looking at cabozantinib in grade 3 neuroendocrine tumours. And this was presented last year, showing you that there is probably a very good disease control rate, in other words, stabilisation of patients with grade 3 neuroendocrine tumours with cabozantinib, up to about 85%. But it's very early days yet. There's also surufatinib, this Chinese biological agent showing very good activity in the Chinese population, is now being tested in Western populations in Europe and the US. And once that's showing the similar sort of activity, it most likely will be approved by the regulatory authorities as well. Interestingly now, as we're getting better and better at the biology of the disease, we can actually grow the tumour in the laboratory, and it's called organoids. So you take a piece of tumour, you grow it in the laboratory, comes out like little spheres, and it simulates the tissue composition of the tumour as well. And you can actually look at and try and identify whether it's sensitive to various drugs. And you can correlate whether the sensitivity of those organoids is the same as the sensitivity of drugs to the patient. In other words, you might be able to predict which tumour is going to respond to which drug. And so there's a lot of work with organoids, not just in NETs, but in other cancers as well. And this is something that it's being looked at overseas in the Chinese, and we're potentially planning to do this at Peter Mac as well. There's also belzutifan. You would have heard about this. This is an agent which inhibits an enzyme called HIF2 alpha. And we know this HIF2 alpha is very overexpressed in tumours which are related to von Hippel-Lindau syndrome. In the case of NETs, von Hippel-Lindau syndrome in a small percentage of patients is the major driver of pancreatic neuroendocrine tumours. So it's just been approved by the FDA and will be approved by Australian authorities for VHL-related tumours, including mainly pancreatic NETs as well. And it is now being tested in a much greater population of patients in a whole variety of tumours, including pheochromocytomas, paragangliomas, and other new pancreatic neuroendocrine tumours as well. And we also have the carboavanec trial, where cabozantinib is now being combined with an immunotherapy agent, avulimab. And it's being looked at in grade 3 neuroendocrine tumours as well. And it's showing promising response rates in early days yet to be developed. And we're also seeing the Chinese playing around with immunotherapy in combination with surufatinib as well. We do know that, as I said, combination immunotherapy works well in this disease. Can we improve that response rate by adding another biological agent, such as surufatinib? So this is a phase 2 trial which is being running in China as well at the moment. Thank you.
So, do we have any questions for Professor Michael? You don't.
You know,
Can we?
sorry.
It's all right.
Do you know why the incidence of has been increasing so much over the past few decades? Is it purely going to include diagnosis, or is it something else?
It's a good question, Andrew. It's possibly related to, we're obviously doing, as you know, we've had better access to CT scans, ultrasounds, MRIs, PET scans. We've also got easy access to colonoscopies and gastroscopies. So I think that we're probably getting much greater access to diagnostic modalities, and we're picking up a lot more incidentally, which is a fine. There's also probably greater awareness of NETs amongst the medical community, and underlying that may actually be an increase in incidence. And we don't really know why, which one is driving that increase. But it's not just in Australia, it's in the US, it's across the world that we're seeing that.
I perhaps ask from a service delivery perspective as a non-PMAC patient, Austin. What's the sort of information exchange like across Melbourne and I suppose other centres where people might be seeing? I guess my point is, like, you know, I feel like my care's been okay, but like, how much, like, is there much interaction between a centre like Peter Mac and clinicians at other hospitals?
Good question. I mean, we do run educational programs. We have what's called a yearly preceptorship, where we invite medical oncologists and other specialists, and we have a full day of how we manage NETs in Peter Mac. Otherwise, we do run multiple clinics and multiple what's called multidisciplinary meetings where there's a whole lot of other specialists involved. And so we run what's called a consultative service. So if an outside clinician has a NET patient, they want to discuss and get an idea of how to best manage that patient, they can refer the patient to Peter Mac. We can then discuss the patient at our meetings, where we look at the pathology, the imaging, and then we may even review the patient after that meeting, and we give recommendations of how we would manage that patient. And so we have often we'll say, well, this is what we recommend, and the patient then go off with that physician. Sometimes we do shared care, where we might see the patient every couple of months after they're being restaged after treatment and see how they're going, for example. So there's various different ways of doing that. So, and we do that with not with metropolitan centres, we do that with a lot of our regional and rural patients as well. Some patients actually have transfer of care to Peter Mac. It's really up to them to see where they're most comfortable.
I just had a question. I'm also an Austin person, and I've asked to be transferred over here. I have lung cancer in both my lungs. I currently been told both my lungs are like Swiss cheese joined together. I have monthly injections and suffer a lot from the bumps that are getting quite bad. I have every side effect with the injections, the fatigue, everything. It's ramped up my pain in my amputee leg, and I'm basically getting nowhere.
Well, I mean, every patient has the right to get a second opinion whenever they like. So it's really, we don't dissuade patients from that if they want to have a transfer of care. It's really just generating a referral from your general practitioner and with all the appropriate information, and therefore we'll go from there. It's ultimately it's up to the patient. Often patients sometimes are referred and what their management is quite appropriate. We say, well, we're not going to offer you any different management, but if you want transfer of care, then we're open to that.
Yep.
Oh, you got it.
Hello.
Hi.
I'm really pleased to meet you. On the Neuroendocrine Facebook page, you are such a respected oncologist. I'm from Sydney. Yeah. I did 3 rounds of Volfox this year, and I had a neurological negative reaction to it. And it's made me examine a whole range of things sort of leading up to the treatment. I've got a great oncologist, it's Nick Pavlakis, so no disrespect to the team, it's a great team up there. But I would be interested in getting a second opinion without trying to offend my existing team. And I wonder, how do you go about that?
Again, it's just organising a referral from your general practitioner.
Yeah.
And basically, as long as we have all the appropriate information to make an informed decision, you're within your right to do that. You don't have to offend your special. I know Nick very, very well, and his team there as well.
The team's great.
Yeah. So I see a number of second, third, fourth opinions. I'm sure some of my patients get second opinions. I'm not offended by that.
Yeah.
Ultimately, it's whatever the patient is happy with.
And I think that's why so many people are reluctant to do it.
Yeah.
Because they know they've got a good team that's doing absolutely everything they possibly can. And it's not their fault, but things happen.
Yep.
And you just want to put to bed a range of
Sure.
issues
Sure.
to do with, yeah,
No, that's fine.
lovely. Thank you.
Okay. Oh, one more. That'll be the last one.
There.
Hi.
Richard Scollier and Georgina Long have used immunotherapy to help Richard's brain cancer. Has immunotherapy been used to treat neuroendocrine cancer? And will Richard and Georgina's work make an impact on all cancers? Perhaps future trials for next patients as well?
That's a good question. We have actually used combination immunotherapy in NET patients as part of clinical trials, and that's where their place should be.
Not in NECs?
No, in NECs and NETs, and we do have data based upon the work from Oliver Klein in that regard, but as part of clinical trial situations. There's also some trials overseas combining immunotherapy with chemotherapy, treating it like small cell carcinoma of the lung as well. And we're still waiting for those results to come through. I think one-off patients trialling immunotherapy like that I think is probably, I don't really think that's ethical at all. And we certainly have had.
Past use by date.
Well, as I said, we don't think the way it's been advertised is probably not appropriate either in the medical oncology community, but it's always better to do it in a properly designed clinical trial situation, which is what we have done, and we are doing that with other immunotherapy trials as well. Okay, thank you.
Flashbang. Thanks very much, Michael. And I just wanted to acknowledge in the audience as well some of our NECA staff, other than me. So we've got 80 sitting at the front here, who is our Marketing and Communications Manager. We've got Kalia, who's doing the laps of the room, who is our Project Officer and Nurse Educator, and we've got Crystal, who is one of our specialist NET nurses on the phone. So whenever you ring, she will be there on a Monday and a Tuesday, and the team is very strong, very supported and very skilled. So please, if you have any questions at all, we're here to support you. So our next speaker is Associate Professor Grace Kong, and Grace is a nuclear medicine physician at the Peter Mac in Melbourne here, Clinical Associate Professor at the University of Melbourne and Sir Peter MacCallum Department of Oncology. Sorry, I'm having problems with my words today. She is the co-chair of the Neuroendocrine Tumour Unit, European Neuroendocrine Tumour Society, which is ENETS, which Michael was talking about, Centre of Excellence, and she has clinical leadership roles as the lead of nucleotide therapy at PMAC, chair of the NET multidisciplinary meeting, which is the multidisciplinary MDM, and the nuclear medicine lead of the upper gastrointestinal tumour MDM. She was a recipient of the Foundation Discovery Partner Fellowship Grant Award. So Grace is going to give us an update on nuclear medicine and also clinical trials, but she's going to give a bit of an overview of what PRT is so that everybody can understand, because I know not everybody would have had it. So thank you so much, Grace.
Thank you very much, Meredith, and good evening, everyone. It's a great opportunity to be here tonight. So I've been asked to talk about the updates on nuclear medicine and clinical trials. So in the next 20 minutes or so, I would like to firstly remind the audience about what is nuclear medicine, and then we'll describe and discuss some current clinical evidence of peptide receptor radionuclide therapy, so PRRT, and then we'll talk a little bit about some ongoing clinical trials in the nuclear medicine space, and then the lead concepts to watch in the future. But because of the limited time, I won't be able to go into every single clinical trials in great detail. So really the focus of today's presentation is to provide an overall concept overview to you all. Now, firstly, what is nuclear medicine? Well, it is a medical specialty using radioactive substances. And usually the radioactive substances is given to people via an injection into the veins. So we can use radioactivity to detect diseases by using very low activity of radiation for scanning purposes. But we can also use radiation to treat diseases by using high activity for targeted therapy designed to destroy the cells. Now, as you all know, nuclear medicine actually plays a very important role in the management of patients with NET, both from the diagnostic perspective, using a PET-CT scanner for imaging purposes, but also from the therapeutic perspective, using peptide receptor radionuclide therapy. Short form of that is PRRT. So currently, the approved product for therapeutic use is actually lutetium, labeled with dotatate. The ability for a modality to combine both diagnostic and therapy together is termed theranostics. Now, how does it all work? The radioactive medicine that we inject can actually directly, specifically target the neuroendocrine cells. So it's very specific. And that is because the majority of NET cells, not all, but the majority have a very special characteristics in that they may express what we call a somatostatin receptors on their surface, a bit like the target. So if you look at the diagram, you can picture the dark red blobs as being the neuroendocrine cancer cells. But on top of it, you can see some purple dots sticking out from the surface. So imagine them to be the somatostatin receptors. So if the somatostatin receptors are expressed on the neuroendocrine cancer cells, the radioactive medicine that we give can actually bind onto it like a lock and a key, essentially bringing the radiation directly to the NET cells. So from the nuclear medicine point of view, it is important to know whether there are somatostatin receptors, because that is how our therapy works. If there is the target, our medicine can bind to the target. But for whatever reason, if the neuroendocrine cancer cells do not express the somatostatin receptors, if the purple bits are not there, then the radioactive medicine will not stick to the cancer, and so the therapy will not work. So how do we know whether a tumor in the individuals have the receptors or not? Well, we can actually see them by doing imaging using PET-CT scan. So by using a very low-dose diagnostic tracer called gallium labeled with dotatate, we can actually take a whole body picture with a PET-CT. You can see on this image, kind of make out as a picture like this, with a patient arms up, with the head, body up to the upper thighs. You can see in this picture here that white is obviously the background, but there are lots and lots of multiple areas of black abnormalities. So those black abnormalities are actually the bony metastases from the net that have gone to multiple sites in the bone. Now, the fact that we can see them lighting up or being black is because they've concentrated the radiation. That means, for this particular patient, the tumors express the target, the somatostatin receptors. If we can see it on the scan, we can potentially treat it or hit the target with a very high-dose radionuclide therapy. And the treatment that we use is lutetium labeled with dotatate. So the difference is between the gallium, which is low dose to see, versus lutetium, which is high dose to treat. Once that's injected, you would expect the targeted radiation to go to the spots, causing hopefully some cellular damage. And then we can also use the PET-CT again to do some comparison. So after treatment, you can see for this particular case that the treatment has worked really well. So there was significant reduction of the tumor burden, resulting in significant reduction of pain and improvement of quality of life for this case. So basically the concept is that if we can see it, we can potentially treat it through the target of somatostatin receptors, which is for NET tumors. Some other tumors may express other receptors that we can target. For example, prostate cancer also has a specific target that we can use to image and treat as well. So lutetium dotatate therapy can work very well for some patients. Now, what about the current evidence of PRRT? There is certainly established and emerging evidence showing that lutetium dotatate therapy is very effective and superior, possibly, to some other treatments as well. So it all goes back to the 1990s when it was first used, and then followed by multiple institutional series worldwide. Most of those series were, smaller group of patients, retrospective studies, but nonetheless really showing that this therapy is effective in multiple scenarios, such as patients with different grade of disease, different primary sites. It can be useful for reducing hormone secretory symptoms and also increasing quality of life, as long as the tumors have the target, have the somatostatin receptors. 2017 was an important year because it's the first big publication of the NET-1 trial. This was the first big prospective study really showing the effectiveness and the superiority of lutetium dotatate therapy compared to a control arm. And this was done for a group of patients with small intestinal NET of grade 1 and grade 2 disease. Based on this NET-1 trial and the previous experiences, this actually led on to fairly rapid FDA approval of this particular therapy in America and in Europe. So it is really now considered standard of care for many patients if they have the appropriate imaging characteristics for it. In the last few years, it's also very encouraging to see that there are more clinical trials now being published and being reported, like the Wakelin trial, for patients with pancreatic NET have shown that lutetium dotatate therapy is superior compared to sunitinib, for example. More recently, the control NET study have suggested that patients with pancreatic NET, the combination of PRRT plus CAPTEM chemotherapy as a combined treatment seem to be superior compared to chemotherapy alone, but I think more data is needed. And again, just a few months ago, the NET-2 trial was published. Again, a big study showing activity and superiority of lutetium dotatate therapy. And this particular trial was done for patients with gastroenteropancreatic NET, but with higher grade disease, so grade 2 and grade 3. So really overall, I really wanted to point out that it is encouraging now to see that there is established and upcoming evidence for lutetium dotatate therapy. So we know that this therapy is effective, but I think there are still questions that need to be answered. In my mind, two main questions that need to be answered. One is that we know that it is effective, but how is it compared to other treatment? I mean, Michael outlined multiple chemotherapy, biological agents before. How does PRRT compare to the other ones? How do we choose which one to go for first? Particularly NETs is a very complex disease with different primary sites, etc. The second main question is, well, how can we further improve the effectiveness of PRRT? We know it works for many patients, but it doesn't work so well for some patients, and it doesn't work for some other patients as well. So there must be some ways that we can further improve the effectiveness. I think these questions really need to be answered by with evidence and by clinical trials. And encouragingly, currently when I did a search recently, there are actually over 35 PRRT-related trials that are being done worldwide that is active. Some are smaller, but some are actually quite big and meaningful trials. So it is a very dynamic space, and hopefully in the next few years, we may have some answers to some of these questions. So to answer the first question, how does lutetium dotatate compare to other treatments? Well, there are actually a few trials that are ongoing at the moment trying to look into this. And these trials are big trials, and they are important trials because I think the results may actually guide our future practice clinically. There are 2 phase 2 trials that are ongoing at the moment. So just very briefly, the COMPARE-NET trial is comparing PRRT to capecitabine and temozolomide chemotherapy in patients with pancreatic NET. The NET RETREAT trial is trying to compare PRRT retreatment versus everolimus in patients with midgut NET. There are 2 phase 3 trials. So phase 3 trials are even bigger than phase 2 trials, really trying to make the comparison. Michael mentioned the COMPOSE trial, which is trying to compare PRRT against chemotherapy or everolimus in patients with higher grade disease. The COMPETE trial, Michael also showed you before as well, is comparing PRRT versus everolimus. So, it's a pretty active space at the moment. COMPETE trial is actually completed recruitment, so hopefully we will hear about the results fairly soon. I'll highlight both COMPOSE and COMPETE because at Peter Mac we actually participated in these international trials. So the second main question that we should think about is how can we further improve the effectiveness of PRRT? I think there are 5 main ways to think about this. The first way to potentially improve to make it work better is by combination treatments. By that we mean combining PRRT, which is effective, with another active agent. So 2, as opposed to giving 1 only, may actually be more beneficial. It may increase the efficacy, or it may increase the sensitivity of radiation from PRRT. There are 4 potential approaches for this combination therapy. If you look at the top corner, A, one of the methods is to improve perfusion, meaning improving blood flow to the tumors, because PRRT is given by injection. If we can increase the blood flow to the tumors, we may increase the delivery of PRRT to the tumor cells. And there are several medications that can potentially do that. The second potential approach is over here, B, which is somatostatin receptor upregulation, meaning we are trying to increase the expression of the receptors on the actual tumor cells, because that's how PRRT gets to the tumors, by binding onto the target. So if we can increase the expression, we may get more radiation to the tumor cells. And again, there are some potential trials looking at this particular combination. The third potential method down there is looking at combining PRRT with another DNA-damaging agent, like combining PRRT with chemotherapy. So both of them together may actually cause higher rate of cell kill. Finally, the final concept is combining PRRT with another targeted therapy, and one of the hot topics at the moment is using a PARP inhibitor. So PARP inhibitor is a medicine that can block DNA repair. In other words, it can increase the cell death. So by combining the 2 together, it may actually make the cell die even more, and more cells to die. Just highlighting that the PARLUNET trial is designed and is actually running at Peter Mac at the moment, looking at this particular combination. So I think it is very encouraging looking through the current trial portfolio internationally. There are actually a number of combination trials that are ongoing, combining PRRT with a number of agents that we have talked about before. But I just wanted to highlight that, with combination trial, the concept is really fantastic, but we really need to do these trials very carefully because we want to have a more effective treatment, but we also have to make sure that it is safe, for patients as well. The second exciting way to make PRRT more effective is by using a new radionuclide. So at the moment, the main radionuclide used for therapeutic purposes is lutetium-177. So in terms of its physics, lutetium-177 emits what we call beta radiation, which we know is quite effective in terms of DNA damage. Another type of radionuclide actually gives off what we call alpha energy. So alpha emission is quite different from beta by several ways. If you look at the blue vertical line down the bottom, the alpha radiation gives off much more frequent events. So there are many more blue dots compared to beta. And each of those blue dots as a radiation event gives off much higher energy over a very short distance. So really what that means is collectively, the path of the radiation can potentially cause much more cell damage. And that's the DNA helix, actually, so it can actually more confidently cause a DNA break and the net cells to die off. The third type of new radionuclide to be aware of actually gives off Auger electrons. Auger electrons is quite different. You can see that the radiation just concentrates in a very, very small dot, so just very short distance. So it's actually potentially very good for targeting very tiny microscopic diseases. If you look at the table on this side, I've highlighted that lutetium-177 is the most commonly used radionuclide at the moment that gives off beta particles. But there are, several other newer radionuclides in the table. For instance, copper-67 may be used and seen much more often in the future, but copper-67 is very similar to lutetium-177 actually, because it also gives off beta, so it may be an equivalent option in addition to lutetium. Terbium-161 I think is quite interesting because it gives off both beta as well as Auger electron. So the addition of the Auger electron may be very helpful in terms of targeting heterogeneous, multiple types of diseases which can exist in the patient, in terms of microscopically targeting tiny, tiny lesions. The bottom of the table are alpha emitters, so they are the really strong ones that gives off very, very high energy. Out of these three options, actinium and lead-212 are the two radionuclides really of most clinical interest at the moment. And just to let you know, internationally, there are actually clinical trials running at the moment using these new radionuclides in early stages. So there's one trial looking at the use of terbium labeled with PRRT. There are two trials looking at lead-212 labeled with PRRT, which is a really strong radiation, and one trial looking into actinium-225 labeled PRRT. So still early stages, but looking forward to seeing the results of these. And certainly I think it is really the aim of the nuclear medicine unit and the NET service to be bringing these new radionuclides to our clinical service under clinical trials in the near future. So we've talked about combination treatments, we've talked about the use of new radionuclides. There are other clinical trials looking into other methods, focusing particularly in a more personalized approach rather than a one-size-fits-all. Because at the moment, PRRT is given as an injection, 4 times, 8 weeks apart with a pretty fixed dose. But you can imagine, different people may have different burdens of disease, may come from different primary sites. So it will be really useful to be able to personalize the treatment a bit better towards the individual. For example, delivering of the radiopharmaceutical, there are clinical trials looking into delivering the PRRT via the intra-arterial routes or more directly to the tumor rather than intravenous. Dosimetry is going to be looking at how we calculate how much radiation we can precisely give tailored to the individual, and using imaging to guide that as well. There are some other concepts with clinical trials looking into establishing PRRT in the retreatment setting. So once patients have the 4 cycles of PRRT, if it has worked very well, it can potentially be used in the future as well. So there are clinical trials looking into establishing the evidence of that. How we use PRRT in timing with surgery is also being looked at in clinical trials. I think we also need better biomarkers to tell us, for example, using blood tests like ctDNA to tell us why some people may respond, why some people may not, and predict who we should prioritize PRRT to be given to. Now, albumin binding is a pretty interesting concept. It's pretty technical, but basically the chemist can alter the chemistry of the lutetium dotatate complex to make it last longer in the blood, to make it more potent. So interesting techniques and complex that we can explore. But as you all know, somatostatin receptors may be expressed in other cancers as well, such as pheochromocytoma or paraganglioma, some small cell lung cancer, and Merkel cell cancer. So there are a number of clinical trials looking into the use of PRRT for other somatostatin receptor expressing malignancies. So what are we going to be looking forward to in the future, in addition to all the trials that are ongoing? I think one of the main interesting area is really trying to find some new targets in addition to somatostatin receptors. So as mentioned, majority of NET have this receptor, have this target, but not all of them. And so if we can find targets for those particular other cancers, that would be fantastic. So there are a few things in the pipeline. So just to quickly outline, number one is called CCK2 receptors, which may also be expressed on a neuroendocrine tumor cell. GLP-1 receptors may be expressed in benign insulinomas, for example. CXCR4 may be expressed in high-grade dedifferentiated neuroendocrine carcinomas, and usually for these group of tumors, they do not express somatostatin receptors. So CXCR4 may be, a promising target for the very, very high-grade cancers. FAP, which stands for fibroblast activation protein, is looking for fibrotic reactions, which may be relevant for neuroendocrine tumors. Just in the last few slides, I wanted to give you some clinical examples of how some new targets may look like. So this is using CCK2 receptor targeting, so not somatostatin receptor targeting, but another target. So this patient has an atypical lung NET. We know that this patient has multiple lesions in the liver. If you look on that side of the screen, that is a conventional gallium dotatate PET scan looking for somatostatin receptor expression. The liver, the lesions are not really lighting up on that scan very well. But if you look at this scan of the same patient, done just a few days apart, using another tracer that targets CCK2 receptors, you can see a big difference. So there are multiple abnormalities in the liver, meaning that for this patient, the tumors, for some reason, are not expressing somatostatin receptors, but they are expressing another receptor. So we can see them. Can we treat them? Potentially, because we can potentially label the lutetium with a CCK2, and for therapeutic purposes. But we need to have more clinical trials to prove that it is safe and effective, of course. The second example is another target called GLP-1 receptor targeting, typically for benign insulinomas. This is a very rare condition. So this is a 54-year-old female who presented with what we call hyperinsulinomic hypoglycemia. Long words, basically meaning that there is very high production of a particular hormone called insulin in the body. Something's making that hormone. And insulin makes someone's glucose go down. So people become hypoglycemic and they may faint, they may collapse. It's a very dangerous condition. And none of the investigations were able to find where the tumor is coming from. So a GLP-1 receptor PET-CT was done. You can see the two dark structures, they're actually the normal kidneys because the tracer has to come out from the body somewhere. But if you rotate the images, if the images are rotated, you can see a dot right in the middle that's black. And that actually localized to the pancreas in these transaxial slides. So with that knowledge in mind, more investigations were done, and the surgeon were able to actually, in theatre, find a tiny, tiny lesion that was resected and was confirmed to be an insulinoma. And after the resection, symptoms completely resolved for this particular patient. So this scan was very, very helpful in this situation. So just a last slide now from me. In terms of just highlighting what's going on at Peter Mac, I think it is a very busy space for us right now in terms of nuclear medicine and NET. There are a number of imaging trials happening. I'm not going to go through that in much detail, apart to say that there are new radio tracers that we're exploring, and in the future, we do hope to bring in some new diagnostic agents, and also particularly to find new targets. In terms of therapeutic trials happening at Peter Mac, there are a number of them. The first two are really looking at genomic and genotypes in patients with NET having PRRT and pheochromocytoma. Trials number 3 and 4, Compete and Compose, we have highlighted before that we were part of the international trials at Peter Mac. Trials number 5 and 6 are combination trials, so combining PRRT with a PARP inhibitor for trial number 5, and combining PRRT with an immunotherapy agent for trial number 6, but that is for Merkel cell cancer, not for NET. Trial number 7, called ICHRONE study, personally I think is a very important one because we are trying to investigate and find out potential risk factors and reasons why some patients may develop low blood counts or myeloid dysplasia after PRRT, which is a potential complication of our radiation treatment. But in the near future, what we do hope to do, as mentioned, is to bring in some new therapeutic radionuclides into our clinic through clinical trials and to explore, further new concepts as well. So just to summarize, you can see that there are increasing number of prospective PRRT and imaging trials, and hopefully that would really provide really robust data and evidence. And the goals, obviously, is to improve the clinical outcome for patients with NET and other SSTR-positive malignancies. But I think, like Michael, all the clinical trials are actually very important because we need to provide the evidence to enable support and, importantly, reimbursements, for NET imaging and NET treatments. So with that, I thank you very much for your attention this evening. Thank you.
So after all that wonderful information, hold on to your questions because we'll do that at the end. So our next speaker, do you want me to? I'll do it. Okay. Is Associate Professor Cherie Chian. Chiang, isn't it? Yep. She's the head of chemical pathology at Melbourne Health and the head of bone at Austin Health. She's an endocrine partner of the ENIT's Peter MacCallum Centre of Excellence and ANZ, BMS and RACP counsellor. So Cherie's going to talk about carcinoid crisis in surgery. And just to let you know, we have got our carcinoid crisis cards over there. So anybody that does have carcinoid symptoms, if you're going to have a procedure or anything done and there's adrenaline, make sure you've got that card so you let the anaesthetist, even your dentist, know about that. So they're over there. And also to talk about spot 5HIAA.
Great, thank you so much. Thank you so much, Meredith, for the kind introduction. And I'm really pleased that there's going to be a card as well. So, in the next 20 minutes, we are going to talk about the overview of carcinoid, the nature of NET that will give you the carcinoid syndrome, and the risk factors that will exacerbate the syndrome into a potentially lethal crisis. So, the true aspect of this is, of course, the card that Meredith mentioned, is we need pre-surgical assessment to mitigate the risks of crisis during surgery. And of course, to do the surgical assessment, we need a test, and that's the urine 5-HIAA, which also helps with the diagnosis. Michael's already talked about the prevalence of carcinoid, but in Australia, it is not rare. It contributes to 3.4% of all new cancer cases in Australia, and of course, it is rising over time. Pleasingly, despite the rise, the survival has improved, thanks to all the good treatment from Michael and Grace. It has improved to 51%, which is lovely. And some of the NET are functional. They make hormones that gives a syndrome. Carcinoid is the most common functional syndrome, and which is why it's been flagged to be spoken about today. Unfortunately, by the time a patient has symptoms of carcinoid, the NET has already metastasized. And so it is a bit of a late feature for carcinoid. So, carcinoid syndrome, Michael's already spoken about where NETs can be found in the lung, in the small bowel, large bowel, and in the pancreas. So what is specific to carcinoid is that mostly in the small bowel or the intestine, it makes hormones, and the hormones are the serotonin. There's also bradykinins, tachykinins, histamine, but mostly is serotonin, and that serotonin serotonin that circulate in the bloodstream is broken down and excreted in the urine as 5-HIAA, which stands for 5-hydroxyindole acetic acid, so we just call it 5-HIAA. It's a little bit of a mouthful. So with the serotonin excess and the other secreted kinins, it causes a dry flush. So it's different to the postmenopausal hot flush, which is associated with copious sweating. And the abdominal pain and the diarrhea, because serotonin will increase fibrosis, so it can cause scarring of the tissue surrounding the intestine. Importantly, can also cause scarring of the heart. And once it's caused scarring of the heart, you can get heart failure. So the middle picture is when you get swelling of the legs. And I've been staring at that banner, and I thought that was a quite nice advertisement of carcinoid, because it's described every single symptom. The rashes. So the rashes is over here. So when you have a net that is going down the pathway of making serotonin, it exhausts the tryptophan. And so you end up having niacin or vitamin B3 deficiency. So it's going down serotonin and it can't actually make vitamin B3, and that causes the rash, the dermatitis. I thought I'll just mention that. So what will exacerbate carcinoid syndrome into a crisis? Mostly it is midgut or small intestine carcinoid, and mostly it is if you manipulate the tumour, you kill the cells, could be via chemotherapy. It has been reported with PRRT. As the cells die, it secretes the hormones, and when it secretes the hormone, it floods the liver. The liver usually would metabolize or break down the serotonin to stop it having an effect. But if there's a lot of load, cancer load that's already gone to the liver's not functioning, it can't actually break down this product. And so the other risk factors are if you have a lot of tumour, so if there's a high disease load, as some of the pictures that Grace have shown, and then you have this problem where there's a lot of secreted bradykinins and serotonin, and it floods the liver, it floods the circulation, and you end up having high or low blood pressure, high or low heart rate, you get diarrhea. So all the usual carcinoid symptoms you see, but just a lot worse because of this flooding of the excreted peptides. Carcinoid heart disease is really, really important in this space. Almost all of the carcinoid crises are in patients with carcinoid heart disease. So what is carcinoid heart disease? I mentioned before that serotonin can cause scarring. So when you have a small intestine net that's making the peptides and it floods the liver, so it continues through the circulation, through the vein, back into the right side of the heart. That will scar the valve of the heart. So you can see where the yellow dot rests. That's the tricuspid valve, where you get the scarring of the valve. And when your heart valve scars, the blood doesn't go in properly, the heart stretches and it sort of fails. And you can also get a low output problem because you might know the blood goes into the right side of the heart, go into the lung to oxygenate, and then go into the left side of the heart to oxygenate the rest of the body. And if you have issue on the right side, you're just not pushing out a lot of blood through to the other side. So carcinoid heart disease, the complications are, of course, abnormal blood pressure, funny heart rhythm. The predictors would be really high disease load. So the more serotonin, the higher your urine 5-HIAA, the breakdown product. and the higher the amount of scarring in the right side of the heart. The anti-proBNP is a marker of how much the heart has stretched. It's also used in heart failure patients. So the more the heart stretches, the more the anti-proBNP would be, and it's also a measurement. The treatment for the carcinoid crisis would be somatostatin analogue, so octreotide, mostly octreotide, lanreotide. And that reduces the production, it reduces the size in some net, and you'll think, well, that's fairly simple. We know how to diagnose it. We know the risk factor. Why can't everyone just get somatostatin analog? And the problem is carcinoid crisis is somewhat controversial. We don't have a standard definition of what constitutes a carcinoid crisis. So would it be a high or low blood pressure momentarily that lasts 10 minutes? But you don't usually watch someone with very high or very low blood pressure for 10 minutes without doing anything. We also don't have good evidence that giving the somatostatin analogue before surgery, during surgery, will completely obliterate the risk of carcinoid crisis. And so with the somewhat confusion in the literature, what we want to do is benefit the risk to the patient and also who should need the infusion of octreotide the most. I want to just highlight a real case. So this is a patient who had carcinoid crisis during surgery at Peter Mac. I might just walk you through the top if the mouse works. So on the top, you can see blood pressure in the red line. So the blood pressure spike and then drop very low over here. And the black dots are the heart rate. So this person was going at 110 heart rate and then sort of plummeted to 45. And then, so you can understand we're looking at labile blood pressure, labile heart rate, and this is during surgery when the surgeon is trying to fix the problem and cut out something useful. You can also appreciate on the bottom here were all the medication that this patient was given in that 10 minutes of labile blood pressure. And so they gave many different agents to cater for high blood pressure, then low blood pressure, and then low heart rate before stabilization. So it's not a nice thing to have during surgery, which is why our anaesthetists, who were giving all those medications, really would like to assess our patient properly before any procedure, so the high-risk patients are appropriately flagged and appropriately given prophylactic treatment, and then we can proceed to the surgery in a controlled manner. Now, even if they have labile blood pressure, then they already have been flagged as a high risk, so all the treatment, all the octreotide infusion is already there, hanging and ready to go. So in Peter Mac, we do have a policy to assess these patients. We look at it in terms of the patient's risk as well as the procedure risk. So shown here, firstly, going from low risk at the top to high risk at the bottom. The low risk are, of course, if they are not making any hormones. So if they don't have carcinoid, we've already done the test. We know they are not making hormones. They don't have carcinoid, so they have no risk. They should have no risk of carcinoid crisis when they don't have carcinoid syndrome. And then you have the highest risk at the bottom, as I said, were those who already have carcinoid heart disease. Not everyone are checked for carcinoid heart disease, which is why we need to bring out awareness that if there's a lot of tumour, if your biomarkers are really high, you really need an echocardiogram in experienced hands, because carcinoid is rare, carcinoid heart disease is rarer, and many community echocardiogram might not report something if they're not aware of it or inexperienced with it. then we look at the procedures in terms of risk. So the lowest risk procedure would be something like a gastroscopy. So you're not touching the tumour, it is invasive, there is some sedation. If you biopsy something that is not the cancer, or biopsy the cancer would give you a higher risk. If you are trying to debulk or remove the majority of the cancer because it's blocking the bowel, well, that's very high risk because that's a lot of cancer manipulation that might cause that flood of serotonin that I was talking about. So based on the risk of the patient, the risk of the procedure, we can say no risk. We don't really need to worry. At medium risk, we might need to worry, and that depends on how well controlled the carcinoid syndrome was before the procedure. Are they already on long-acting somatostatin injection? And then the anaesthetist, based on these risk rubrics, will decide whether they need to already have the octreotide infusion at the ready, so not using it yet, or to infuse it at the time that they put the first invasive line in. And of course, a very high-risk patient, we essentially just ensure everything is there. So in case of blood pressure lability, as you've seen, or the requirements are already there, the patient's already had a bolus to stop any of the secreted serotonin to lock onto the receptor, they already have the bolus going, and we really try to optimize their therapy. In fact, for the carcinoid heart patient, we really try to ensure their valvular surgery is done first before doing large debulking, so that they've got a good heart that's able to carry them through a major surgery. So now we're going to move to the tests we do to assess our patients before their planned invasive surgery, as well as for diagnosis of carcinoid syndrome. There's a lot of confusion and underutilization of 5-HIAA. Partly from the patient point of view, they are often confused about what dietary restriction is required. Because although serotonin from NET breaks down to 5-HIAA, there's a lot of food that's also rich in serotonin. So that's the banana, we're all familiar with. The plantain is a yellow-green thing next to it. It's a type of banana, but it's mostly in Southeast Asia, and that's even higher serotonin than banana. So what happens when you eat bananas? Well, it would increase your urine 5-HIAA by 30-fold within 4 hours of ingestion. So it's a really strong effect. And it will be persistent at 24 hours after you've eaten your banana. So it would still be at 3 times higher than your baseline. Nuts can also do this, not as bad as bananas. And certain fruits and vegetables, so the pineapple, the plums, tomato, unfortunately, the sauces, the pasta sauce, the soup, a lot of things has tomato in it. That's a bit not obvious to the subject, and kiwi fruit and avocado. And that's actually all that is in our guideline for avoiding. So you only need to avoid these food for 2 days and the day that you collect the urine for the 24 hours, so 3 days in total. So that's not a very big ask. There are other things. So a lot of people ask about alcohol. It's really just the day before and the day of the urine collection. Some of my patients think, too hard basket, the instruction has too many food groups to read, and they say, Cherie, I'll just do the white diet, that's milk, yogurt and bread, because then they don't need to think very hard. But if you do that, it's generally a low-salt diet, and a lot of people don't realise if you have a low-salt diet, it will increase your urine 5-HIAA by 50%. 50%. There's a few other considerations. And the hidden things are over-the-counter supplement. So you say, well, I'm not going to take serotonin, but it's not called serotonin. It's called 5-hydroxytryptophan, and is readily available. It's meant to help sleep, make people calm, and so forth. If you're on any of these, you'll need to stop it for 2 weeks because they're very high doses. It really boosts up your system. It'll come out in the urine, and then the doctor's going to look at the high urine 5-HIAA and think that, oh, what's going on? Is this disease progression? Are things getting worse, or is actually just a supplement? A very common question that is asked is, well, what about my antidepressant? What about my anti-migraine tablets? Because many antidepressants, the sertraline, the fluoxetine, is a selective serotonin reuptake inhibitor. So although it has the word serotonin on it, there's no good evidence that the antidepressant will cause any problem with the 5-HIAA. So you don't need to stop. No need to stop. Just do the test, and then your clinician will just interpret as required. So that's the instruction for how to collect. But there are also many online instructions. So I just looked up, actually I just Googled a 5-HIAA collection, and then this is Memorial Cancer Center in USA, I assume. It sounds important. It's quite a famous cancer center, and yet their online instruction says do it 3 days before your urine collection. So it's 3 days plus 1, that's 4 days. And what is the evidence for 3 days plus 1? Well, there isn't any because a review has noted that 2 days is fine. And they also ask for a lot of other restrictions, such as coffee, tea, energy drinks, and chocolate. I don't think I can survive 4 days without my coffee, so I would be quite reluctant to do a urine test for that, in fact. And what is the evidence for caffeine? There isn't any. If you drink 5 cups of coffee a day, it will not increase your 5-HIAA. 250 grams of chocolate is quite a lot. I don't think anyone would try to drink 1.5 litre of tea or coffee, but just to show you that caffeine, 960 milligram, is quite a lot. It doesn't change anything, so it's fine. And they put eggplant, and a lot of this dietary restriction is somewhat based historically on things that's done in the 1970s. And there's a grain of truth, but not more than that. So you need 10 eggplants to increase by 5 micromoles per day. The high urine is more than 50 micromoles per day. Usual people just have 20, 30 micromoles per day. So you'll need to eat a lot of eggplant to actually become abnormal. So I'm really pleased to say within Australia we do have a harmonised guideline, and we have a patient instruction. We also have a doctor instruction in case they're tempted to stop antidepressants. And I'm really also very pleased that NECA has the patient instruction on their website, so it's readily available, even though your laboratory is meant to give you the bottle and the instructions, sometimes they don't. So how do we overcome the fact that people don't like doing 24-hour urine and they'll rather do a spot because spot you can do it any time. So they are studying to look at how well they correlate, and it correlates really, really well. So this is a published study where they look at the spot. So when you do a spot, you need to look at how dilute the urine is, and hence there's a ratio there. And the sensitivity and specificity is really good. We've done the study in Peter Mac along with the Royal Children Pathology team and our oncologists. We also found that the spot is very good. So there are many advantages of just doing a spot because it's one less day of food restriction. You just need to restrict for 2 rather than the 1 day that you're doing the 24-hour urine. You can do the urine test at the time of blood test. And you don't need to babysit the big bottle because most people need to stay home. They can't go to work with a big bottle. They can't go shopping with a big urine bottle. You also don't need to hide the big bottle when you have guests coming over for dinner. In fact, 24-hour, most people are not very accurate. They do 16 because they just got a bit tired, or they do 26 because they slept in. So it's not very accurate anyway. And a lot of the time, if they've got book surgery, they don't want to wait for another 24 hours to collect the urine. So I will stop there. I believe our questions at the end. Thank you for your attention.
Thanks, Cherie. And yes, questions at the end. So our next speaker is Dr. Erin Lain, and she's a senior clinical dietitian and researcher in the Nutrition and Speech Pathology and Health Services Research Department here at Peter Mac. She has a particular interest and experience in the nutritional management of gastrointestinal cancers and neuroendocrine tumours, including completion of her PhD in 2020 on the topic of nutritional related symptoms, complications and quality of life for people with neuroendocrine tumours. Since her PhD, Erin has led nutrition-focused research in neuroendocrine tumours, including the international development of a NET-specific screening tool, and is the chair of the Nutrition Working Group for the ComNets Research Collaborative. In 2016, she also led the implementation of a dedicated nutrition service for neuroendocrine tumours and its integration into the multidisciplinary neuroendocrine clinic here at Peter Mac, which is still active today. Erin is passionate about optimising models of care to improve nutritional management and quality of life for people with neuroendocrine tumours and other cancers. So I will close that one down for you. Okay, that one. And that one was yours, wasn't it? There you go. Thank you.
Hi everyone, pleasure to be here, and thanks Meredith for the introduction. So I'm going to be talking about nutrition, a little bit of change of tact. I've got a little bit of research littered throughout my talk, but really I've come today with a lot of practical strategies for you. I imagine there's a lot of you in the room who have nutrition questions or symptoms that you're experiencing, so I'm hoping that I'll be able to answer some of those queries today and obviously take questions towards the end of the day. So we know in terms of literature, which is growing in terms of nutrition and NET, certainly we have a lot of nutrition literature for other cancer types and other gastrointestinal cancer types. But for NETs, we know that a lot of the nutritional complications really surround the symptoms that people experience. So things like diarrhea, abdominal pain, bloating is an example, and they can affect nutritional requirements. That could be related to nutrient absorption, but also somebody just not eating normally as they would because of how they're feeling with these symptoms. So food consumption and behaviour change has been shown in literature. So this is going to summarise sort of in a snapshot what we sort of know from literature that's been published from Australia, Europe and the US. So we know that dietary change, and there's only a couple of studies, one being one we've done here at Peter Mac, dietary change and restriction is really prevalent in neuroendocrine tumours, and that's we've done a study on prevalence in more your gastrointestinal, pancreatic neuroendocrine tumours, that almost up to 60% of people, and this is sustained over months of time, we did it like an overtime longitudinal study, and mostly because they had diarrhoea, they had ongoing wind, bloating, gas and low appetite. What does it actually mean, though, in terms of people's malnutrition risk or nutritional status? So surprisingly, rates of malnutrition and weight loss are actually quite high in people with neuroendocrine tumours. Fluctuate a lot. We also see rates of weight gain as well in some patients, particularly those that are responding well to treatment, but that can have its own problems in terms of body image and identity as well. Malnutrition rate sitting at almost 30% is about the same as our overall rate for cancer in general, and obviously that fluctuates depending on what kind of NET you've got and where it's located. We know that the higher grade NETs and the NECs are more likely to be malnourished than those that are on chemotherapy. Interestingly though, and actually the rates are even higher than this based off a couple of recent studies, but sarcopenia, which is actually a measure of muscle sort of volume and function is actually really prevalent in people with neuroendocrine tumours, what we've seen in a few studies emerging in Europe and one small study in Australia. What that means is that people actually have underlying muscle loss, but that could be occurring even if your weight is stable. So a lot of people might have a healthy BMI, might have a stable weight, but we've actually shown that there's some muscle loss happening in the background there. So that's really interesting for us to know as clinicians, but also for you to be aware of in terms of your strength and function. It's quite important. And Cherie alluded to this a little bit, but there are some vitamin deficiencies that are at risk in patients with neuroendocrine tumours. So niacin, particularly in people with serotonin-producing tumours and those with carcinoid syndrome, can be prevalent. And fat-soluble vitamins as well, so particularly related to any malabsorption that might be occurring in those people with diarrhoea. And I'll talk a bit more about the risks of those. So what are our general goals of nutrition for NETs? So there's a few different ones, and we certainly adopt these principles in our dietitian NET clinic here at Peter Mac. So we want to minimise weight loss and improve nutritional status and identify problems with nutritional status, malnutrition and weight loss where we can. Optimise quality of life, so certainly eating, drinking, socialising with food is really important, so working with people to optimise quality of life and eating behaviours. Improving response to and recovery from treatment, so we know that optimising nutritional status, keeping your weight steady, eating a healthy balanced diet actually does help you recover from treatment and get through your treatment easier. Same with immune function, and they're a little bit related. We want to assist in symptom management. I would say probably half of the patients we see here in our NET dietitian clinic come to us for symptom control and advice on diarrhoea, bloating and problems with eating, not just because they've had weight loss, which is very different to some of our other cancer clinics here. We want to monitor and treat vitamin malabsorption. I'll talk a bit more about that. And we've really got an important role in multidisciplinary care, as Michael said, and we work closely with the doctors, nurses and other professionals in the MDT clinic here. So some general principles, and this is something for everyone to take away, even if you're someone who's sitting there, healthy weight, not too many concerns with nutrition. This is generally what we expect in terms of what a healthy weight means. So it's your weight in kilos over your divided by your height in metres squared, and I've got the ranges there for your age group. We want to make sure people are as close to that healthy range as possible. If you're sitting just in the overweight range, that's also not too concerning as well, as long as you're staying pretty steady. Generally, eat a high protein diet, ensure adequate and varied intake of various amino acids, so lots of varied protein sources if you can. Eat frequently and don't skip meals. We want a variety of foods every day. Diet generally lower in salt and fat and sugar, but obviously if you're feeling unwell and just needing to eat what you can, it's okay to have more of those. But generally, if you're someone in the room who's asymptomatic, eating a healthy diet, there's nothing special you need to do for your neuroendocrine tumour. Eat a healthy diet, enjoy your food, try and keep a healthy weight, and they're the main things you need to do. I'll go into some of the more symptoms that we can help manage with nutrition now as well. So for those that do have nutrition-related side effects from their NET or treatments, and it can be a really complex relationship there. So a NET itself can cause symptoms for various reasons, depending what type of NET you have and where it's located, what hormones it releases. Also the treatments you're on can cause additional symptoms as well. So I've got a list there, which is not exhaustive by any means, but some of those might look familiar to you. Some of the more common ones we deal with in our clinics are diarrhoea, fatigue, weight loss occasionally, and often bloating, gas, abdominal cramping as well. A little bit about carcinoid syndrome that Cherie just talked about as well, but in the nutritional context. So we know that carcinoid syndrome results from overproduction of serotonin, and these are the various symptoms that people experience, and they might experience a couple of those or all of those. There's a lot of talk, and some of you might have seen this on patient forums and chats about foods and drinks that can trigger your carcinoid syndrome to be worse, which I'll talk about in a minute. We also know that a high production of serotonin can lead to vitamin B3 deficiency, which Cherie mentioned, and I've got a diagram there showing you with the exact mechanism of that happening as well. And as I mentioned earlier, the rates of prevalence are relatively high, so this is something to be aware of if you're someone who's knows to have high levels of 5-HIAA, you've got a serotonin producing NET, or you've got those symptoms of carcinoid syndrome. It's always worth checking with your medical professional if you think you might need to take a niacin supplement. This is why. So tryptophan, which Cherie mentioned, it's an essential amino acid. It's one of our 12 essential amino acids. So if you're someone who eats a variety of proteins over the day, it's highly likely you're getting adequate amounts of tryptophan in your diet. However, and we don't usually need to take supplements to ensure that, In a normal person or someone without a neuroendocrine tumour, majority of the conversion of tryptophan goes to niacin, which is that NAD down the bottom, and very little, like 1%, goes to 5-HIAA. What happens in neuroendocrine tumour, there's a real shift in volumes, and that's where then you get that deficiency. So taking tryptophan supplements isn't necessarily the solution here, because it's just going to keep getting converted in someone with a serotonin-producing NET. A little bit more about trigger foods. I'll talk about niacin supplementation in a little bit. This is very anecdotal, so I want to point this out. Where we're probably lacking the most research in neuroendocrine tumours is what is the optimal diet for people with a NET. I'd really love to do some research in this space one day, but they are tricky studies to design and undertake. At the moment, some of our key triggers that we see being really effective in the clinic when we're talking to people with active carcinoid syndrome are meal size. So if you're someone that eats large meals, converting to your smaller, more frequent meal is really effective. That's for people who have sort of symptoms of bloating and poor appetite as well. Fat content, spiced food and alcohol, anecdotally, is known to really worsen carcinoid-related symptoms and diarrhoea. So think about your content of those as well. What are meals moderate to high in amine? So often a lot of people talk about cutting out different kinds of foods that they feel improve their carcinoid syndrome, or foods that they feel exacerbate. And certainly I've come across patients that have taken these foods such as chocolate or bananas, a lot of them very similar to the ones that Cherie mentioned in the ones you need to cut out before your urine test. But what we really want to make clear is they're very individualised in nature. So I've met multiple people with carcinoid syndrome, and certainly probably a couple of them cut out bananas. The others had no problems with bananas. So there's really no consistent message we want to give to people about this, and you really need to be investigating this with a dietitian if possible, and also looking at a food and symptom diary. So hopefully people are aware that there's one available on the NECA website to download, and this is what it looks like. Usually we request that people record everything you eat. That includes drinking, from waking up to going to bed, every symptom you experience, no matter how small or large it is, for approximately 2 weeks or more. If you take that to a dietitian, we can then look and pick up what some of your individualised triggers might be. That's really your best method of knowing what's going to work for you, and we do that really commonly in our clinics here. I just wanted to point out as well, this is from a relatively older article, but it really highlights how common it is that a lot of people with NETs are diagnosed with IBS, food intolerances, functional bowel diseases even prior to their NET diagnosis, but also remain confused around whether they have these existing conditions because of some of the symptoms they experience. But really we have very little evidence that food intolerances are common in NETs. They're often misdiagnosed. If you have been diagnosed before, don't assume now you've got a NET diagnosis that that's actually what's happening. Definitely see a dietitian or a gastroenterologist and get further advice. Food and symptom diary is another step to check if that's a problem for you. And evidence really at the moment is mostly anecdotal. So we tend to encourage a balanced diet and discourage severe restriction for most people. Because what we're noticing too, and we suspect in some of the literature why sarcopenia rates are so high, even in people with a healthy weight, is that dietary restriction occurring in such a large proportion of the population. You may not be getting the fully balanced diet that you need to be. A little bit about fullness and bloating, because we get asked a lot about this in clinic. So if anyone's suffering from this who's here today, hopefully you find this helpful. We tend to suggest avoiding gas-forming foods, so onions, garlic, cabbage, things that anybody can often feel like makes them a little bit gassy. Trying a low-fibre diet, so things that are not so high in grains or nuts or seeds. Fizzy drinks and chewing gum, so chewing gum makes you gulp air as you chew it, so that will make any bloating or gas worse. Fizzy drinks, anything with gas in it, will also make things worse. Eating small and often. And interestingly, we did a survey through one of our studies of our NET patients that we see here at Peter Mac, and I would say 60% were modifying the number of foods they eat and the types and the frequency of the day. So that's a common one that people often do to cope. A little bit about diarrhoea, because this can be really complex in the NET space. And certainly we help people manage diarrhoea a lot, but obviously it's very much a combined management with medical professionals, including gastroenterology. So this is just a bit of a snapshot of some of the causes and treatments of diarrhoea in neuroendocrine tumours. So this can help people troubleshoot what some of the treatments or who they need to talk to about management. So we know that somatostatin analogues, whilst they are designed to reduce treatment burden in NETs, and they do in many people, there actually can also be a side effect of worsening diarrhoea in some people who have SSAs, particularly those on higher doses of SSAs. And that's because what SSAs do is they suppress hormonal function, but sometimes that can actually suppress what your pancreas is normally trying to do with hormones and enzymes to help you digest. So it can limit your ability to digest properly in some people, certainly not in everybody, but it is a known side effect. So if you're getting worsening diarrhoea on an SSA, particularly if it's in sort of 5 to 7 days after your injection each month, it may be that you've got this sort of, your pancreas is not working as well because of the injection, then you really need to chat to someone because that can indicate a malabsorption going on, and that can show you pancreatic insufficiency. Problems with that is then fat malabsorption. So if that goes untreated and diagnosed, if you don't absorb your fat very well because of the enzymes not getting properly released from the pancreas, your vitamins that are absorbed and sit in fat in your body also can be malabsorbed as well. So that can lead to that fat soluble vitamin deficiency that I mentioned before. We know that various surgical resections, if you have part of your bowel cut out, can also reduce nutrient absorption as well, and also bile acid absorption, leading to diarrhoea and electrolyte problems. Carcinoid syndrome we've talked about, and that's due to the serotonin hypersecretion. So always talk to your doctor or request a dietitian referral to know the cause of your diarrhoea, because there can be various causes, I've stated in NETs. Eat little and often, it's probably the main message I'm giving away today. In terms of fibres, what we tend to encourage is those insoluble fibres, so anything you can see, so grains, seeds, crusts on bread, skin on fruit, cut down on those. But other things like fruit flesh, oats, you still want some fibres in your diet because that's healthy for your gut and they're okay to have. In terms of steatorrhea, so not everybody knows that term, but that's essentially if your bowels become pale at all, floating, really smelly, oily, that is indicating you've got too much fat that you're passing through your bowel that you're not absorbing. So that can sometimes mean that, and this is quite common after an SSA injection as well in those few days after. The main treatment of that is having pancreatic enzymes orally through a tablet that can help manage that absorption as well and help reduce vitamin deficiencies if they are occurring. So have a chat to your doctor if you're worried, if you think you're getting any of those symptoms from your stools. Probiotics, which we get asked about a lot. So this is good bacteria. So this is live, good bacterial cultures that can help control growth of harmful bacteria. We don't probably know a lot about the microbiome, which is kind of the balance of good, bad bacteria in someone's gut in NETs. I know there's a few people interested to look into that. But at the moment, unless you're having high-dose chemotherapy, which is a contraindication, taking Activia, Valia yogurt, Yoplait, capsules, probiotic capsules can be beneficial if you're finding you're having lots of diarrhoea or you've got altered bowel habits as well, and it's perfectly safe. The other thing about diarrhoea, it's not just the fat-soluble vitamins, but all your electrolytes, if you have ongoing watery diarrhoea particularly, and you're not replacing those through an electrolyte drink. So hydrolyte, gastrolyte, not as good, but Powerade and Gatorade can be really good as well. But drinking frequently is important. Vitamins. So what we know about vitamins is mostly niacin and fat-soluble in terms of some of the literature and what the prevalence is of those. There's a little bit of evidence in B12 and iron, but I'll go through each of them. So niacin being B3, so this is, as we know, risk factors for those with serotonin-producing NETs and carcinoid syndrome. The best test is a 24-hour urine test, unfortunately. Blood tests won't show a reliable marker of what your niacin looks like. So if you do want your niacin tested, it's available in most countries. So in Australia, for example, our samples here at Peter Mac go to Sydney, so we don't actually have analysis here in Victoria, but you can request the test and get it sent off so if you're in your public health service, that'll be covered obviously by Medicare, but privately it can be a little bit expensive. And what we tend to say for people who have either carcinoid syndrome or have sort of frequent diarrhoea, or you've been told that you've got a really high serotonin producing NET, just taking a niacin supplement from over the counter can be really helpful daily. It's very safe to take, they're water soluble. You tend to excrete any excess through your urine. In terms of fat-soluble vitamins, we don't test them routinely here at Peter Mac, but we tend to suggest people take pancreatic enzymes, so chat to your doctor if you're concerned that your bowels are changing in colour or consistency and that you might be at risk of fat-soluble vitamin deficiency. And the main risks for B12 and iron are people who've had stomach or bowel surgery, low meat intake, or if you're a vegetarian, are the main risks, and there are options. So they're very easily tested, so my best advice for those is to ask for a general vitamin screen test that includes those, and that'll give you the answer if you're deficient or not. Before I finish, I just wanted to mention some progress we're making in terms of identifying nutritional issues in NETs. So as you know, I mentioned at the start, rates of malnutrition and sarcopenia are really high. We scoped out sort of how many people even in the population of NETs coming through Peter Mac here were seeing the dietitian, and it was less than a quarter. So there's higher rates of people having problems with nutrition that are actually getting to see a dietitian, and we're very lucky here at Peter Mac because we have a dedicated dietitian clinic for NETs. We're the only centre in Australia publicly that has that service, so we're aware of a lot of other health services and centres that don't have access to a specialist dietitian, but really access to any dietitian is important for a patient with a NET. So what we've done, we did this a couple of years ago in collaboration with Royal North Shore Hospital, NECA and Deakin University, is we actually took expertise from international health professionals across Australia, New Zealand, Europe, the UK, US and Canada, so covering most regions of the world. Underwent focus groups with these health professionals, and then a 2-round modified Delphi survey. So that basically means an online survey that we emailed out to people to get their feedback on a tool that we've created and the key items that they think are relevant to NETs and nutrition. That sort of went back and forth, and we refined the tool, and then we sent it out for consumer testing. So basically got patients to complete the tool, tell us it was readable and acceptable, and they felt it was easy to complete, how long it took to complete, and we did some reliability testing as well, which means we got them to complete it at 2 time points a week apart to see if they had the same answers, and we had really positive results from the patient testing. It only took about 5 minutes for our tool to complete, and I'll show it to you on the next slide. And it was really reliable from what we saw, and as you can see, we had really good buy-in across countries. We recruited a lot from the ENET Centres of Excellence as well in Europe, so some great expertise really came together to say these are the issues for patients. We have nutrition risk screening tools that we use in cancer anyway, but we identified that for NETs, there are some specific issues which are sort of listed there in the blue that are more important, that might actually, if ongoing and not treated and not addressed with a dietitian, will lead to further problems with food intake and potentially risk of malnutrition. So what we've done is combined an existing nutrition risk screening tool, which you don't have to remember what it is, but it's called the PGSJ short form, which is used to assess malnutrition risk in cancer patients. And then we've got some additional NET-NS modules, so the NET specific questions. So that's been developed and it's really ready for its validation stage now. So keep an eye out, because once we get through validation, this will hopefully be up on the NECA website and for people to be able to complete this. So it's designed for patients to complete themselves, so you can take it to your doctor and say, this is my nutrition risk score, I might need to see somebody. That's sort of the idea. Lastly, research, what's happening, because there's a bit happening in this space. We're going to validate and implement their NET-NS, so we have submitted an international grant to get funding to do that across Australia, New Zealand, Canada and the US. We're going to do some local trial of this screening tool here at Peter Mac to see if it's effective and picks up higher rates of patients needing to see a dietitian. Here at Peter Mac, we're also doing a big retrospective analysis, so looking back on all our historical CT scans to get some better prevalence data for sarcopenia, using CTs and artificial intelligence just to help us do it a little bit faster here at Peter Mac, so look out for that, because we otherwise haven't got a lot of Australian data for sarcopenia in NETs. A prevalence study for niacin B3 is also happening in Australia. There's currently no prevalence data amongst people with NETs for B3 and niacin in Australia, so we're hoping to get some data in collaboration with Royal North Shore. The COSA, so this is the Clinical Oncology Society of Australia nutrition guidelines. So these are the first published nutrition guidelines for NETs, came out late last year. If you Google COSA neuroendocrine guidelines, you'll be able to access them. you are allowed to read them as patients as well as health professionals, so please have a look at those if you're interested in where our evidence sits at the moment for nutrition and what some of the recommendations we're providing to health professionals. And as I mentioned as the intro, we're also undergoing an international collaboration to develop international guidelines with Canada, New Zealand, and also some European dietitians are getting involved in that as well. So we're working together to really get the best evidence for people on how we should be managing nutrition the best we can. Look out for some resources on the NECA website if you haven't seen them already, developed for nutrition and easy to download as well. Thanks.
Okay. So now we've got Kate, who is a clinical nurse consultant here and nurse practitioner candidate. Kate's a registered nurse with graduate diploma in psycho-oncology, also holding a Cert 4 in workplace assessment and training, as well as postgraduate qualifications in breast, prostate and lung cancer nursing. Kate has a career spanning more than 30 years in cancer care in a mixture of clinical program management and supportive care roles. The focus on which of most of this work has been in providing specialist cancer information and support in the provision of helplines, face-to-face and online peer support and education programs and health professional networks. Kate has specific experience and expertise in the nursing care of people with neuroendocrine tumours, having been with NECA for quite some years, 5 years, with this being her primary area of focus for the last decade. Throughout her career, Kate has maintained a passion for creating and maintaining innovative programs that strengthen the delivery of holistic and supportive care. So, thank you. And
I'll start while we get the slides up because I want to make sure that we've got time for questions and answers at the end. So, don't know. We'll see. So I wanted to talk a little bit, I've been asked to talk about nurse-led care, which is a fairly new way of working, certainly for Peter Mac, but also in other cancer centres nationally and worldwide. So I guess I wanted to, and I'm going to maybe give you some familiar faces in the slide. So this is one of my colleagues, Meg, talking to a patient in her phone clinic. But in terms of the background to this, well, you know, you might ask, well, why would we have nurse-led care? We've got great oncologists who are very good at shrinking and nuclear medicine physicians and people who are really good at treating tumours. And I guess my answer to that is that you're not just a tumour, you're actually a person who has a tumour, or you're looking after or working with someone, your family member or a friend of someone who has a tumour. And so it's not just about impressive looking pictures of PET scans where tumours are shrinking. I don't really see any point, well, so much point in subjecting to someone to a long and miserable life if we can give them a longer life and also get them living that best life. So that's my kind of focus. So we know that people with NETs have lots of unmet supportive care needs, and that's, I guess, as a nurse where my superpowers come into play. And also, I guess, you know, evidence tells us that multidisciplinary care is the best model of care in contributing both to improved quality of life, but also actually prolonged life. So that's something that at Peter Mac we've been sort of extending into. So the NET Nurse Clinic, and that's not a patient, that's actually Rachel, one of our other nurses who commonly fills in for me when I'm attending lectures and uni courses and things. So we established the NET Nurse-Led Clinic in 2023. And it started off with patients with low to intermediate grade neuroendocrine tumours. So we're talking about people where the disease might be more stable, but a sad irony of that is that often they're the people with lots and lots of symptoms because they've got lots of hormonal stuff going on. And also, they might be living with the ongoing impact of treatments for a really, really long time. So there's that slow water drip torture going on that might mean that, you know, you have reduced quality of life overall. So some of the focus of the clinics, you can see there, it's shared care with the medical oncologist. So, sometimes I get asked, do I see patients independently and treat them independently of their cancer? Well, no, I don't. And even when I'm qualified as a nurse practitioner, I won't be doing that. So it's very much in partnership with a managing medical oncologist. And it's symptom-specific focus for that clinic. It's also looking at patients or working with patients who are starting a new therapy. So, that might be the injections and getting them established on the injections. Sometimes they come to my clinic for that first injection where they're learning to self-inject, and I think that's extremely brave. But sometimes some of those other therapies like oral chemotherapy and that sort of thing. And also, I think, along with that multidisciplinary care, the nurse consultant, certainly in our model of care, is often the gateway. I'm often the gateway to refer to and work really closely with our other valued members of our multidisciplinary team. So certainly I work very closely with our diet consultants. Think of the right. I'm running out of words too, as well as people like exercise physiologists. So all of the allied health, as well as the other medical professionals involved in the care. So I just very briefly want to touch on a couple of things that we've been working on. One of the things was working with what's called patient-reported, or PROMs, which stands for patient-reported outcome measures. Some of you may have heard and downloaded the Planet app. As part of the Planet registry. And when we started up that Net Nurse Clinic, we thought, maybe that would be a really handy way for patients to be using the app before they come to see me in the nurse-led clinic, so I can get a bit of a snapshot of what their symptoms are like and make sure that we're focusing on the thing that's really important for them. So we trialled that in 2023, and interestingly, it didn't work so well in that context from a clinical point of view for a variety of reasons, which I'm going to save my words and not tell you about the intricate reasons. If you want to know more, you can talk to me afterwards. But what we've done, so the Planet app is still quite a valuable tool in terms of the research part of that study, but not so useful in a clinical sense for helping me look after people in terms of their symptoms. So we're doing some more work, and I guess this is the last bit of my slides, you'll be pleased to know, because I know we've got lots of questions and answers waiting, but we're doing some work to identify a different way of capturing those PROMs, or patient-reported outcome measures. And one of the things that we'll be road testing, like Erin said, is her nutrition screening tool, as well as a what's called a distress screening tool. So that would be something that will come for people who come along to our nurse-led clinic over the coming times. The other thing I just wanted to touch on very briefly was that we're involved in a study that's all around Australia called the AusNet study, and that's a new level, a new model of nurse-led care, focusing specifically on what we call survivorship issues. A lot of people, one thing that I know is that a lot of people with NETs don't actually call living with NET survivorship. They don't really necessarily identify with that term, but from medical lingo term, it means all of the associated issues that you're living with day to day as a result of having had or still have your cancer. And so that clinic is focusing on that, but also very closely working with that person's GP and getting them more involved in that patient's care. So that's a really interesting study that we're looking forward to the results of. I'm going to stop because I know we've got questions and answers. But before I do, I just wanted to highlight one of the things I really love so much about working in neuroendocrine tumour space is the fact that I get to know my patients really well. And I've got patients who I've been working with in various support groups, in various organisations since 2010. So it's really one of the things that I think a lot of health professionals working with NET patients say is it's just so wonderful to get to know people really very well. One of my favourite things is when people text me photos of their pets. So that's just something to keep us smiling.
Okay, so as I said, you have to put up with me for a short period, and this is going to be like a speed date with letting you know what neuroendocrine cancer is up to, because, I do want to give some time for some questions and things. So just given everybody else's resumes and everything. So I'm Meredith Cummins. I'm the CEO for Neuroendocrine Cancer Australia since 2022. Been working with, when it was the Unicorn Foundation back in 2018, and I was the project officer, nurse educator. Originally, it was a new position that was made. So I'm very pleased to be working with neuroendocrine cancer and with the team that we've got. So just some quick stats. These are the most recent ones, which were the 31st of August this year. So there's 5,755 new diagnoses each year, and for the last year anyway. And this is just in comparison to other cancers. And currently the survival rates is at 53.8, and we're looking at the incidence of it being basically 21 per 100,000. So across the board, it's not a rare cancer anymore. There's lots of different subsets of neuroendocrine cancers that are rare, but on the whole, not. So I've got some music to talk to. Just some other interesting stats I'll just quickly go through. 30% of patients live 300 kilometres or more from the closest centre of excellence. 1 in 55 Australians has the chance of developing a NET, and as I just said, 7th most commonly diagnosed cancer in Australia. There's 29,350 plus people living with NETs in Australia. And there's 1 Australian is diagnosed with a neuroendocrine tumour every 90 minutes. The average patient waits around 5 to 7 years for a correct diagnosis. 1 in 2 patients are diagnosed with an incorrect diagnosis originally, and the worst stat of all is that 60% because of that misdiagnosis have stage 4 disease by the time that they are diagnosed, which means that they're no longer going to be curable. So I won't go into too much detail, but as our vision is to be champions of early diagnosis and cure, and our mission is to assist and support everybody in the community, lobby for things, raise awareness and knowledge with the medical community and general public, and also encourage and support research in the area of neuroendocrine cancer, which we have been very successful with being part of. So patient support, we have the Net Nurse support line, which is having around about 200 contacts a month, although we did have a recent influx where we had 54 calls in 24 hours, which was just like mind-blowing. And it's continuing to increase. So we've got Crystal, who is on Mondays and Tuesdays, and we've got Dana, who is on Monday to Friday. So we've got good coverage there. We've also got a dietitian who is now working with us alternate Mondays and doing some additional consults. And we have a counsellor working with us 2 days a week. So we're increasing our services. Resources, we've got 4 explainer videos now, including PRRT and familial nets, and we've also got support groups across Australia, face-to-face, and also the Zoom meetings. We will be looking at how we can enhance the face-to-face meetings across Australia, but we need to sort of ensure that we've got facilitators to do that. Private Facebook group has over 2,200 active members, and we remain the main referral service for nets. Just with some of the research, we've already had a little bit of a chat about Planet Registry, which we're hoping to increase. The AusNet nurse-led shared care, which Kate's just spoken about. Also looking at treatment in the community, menopause study, there's a nutrition screening tool, genomic studies, and there's also a PET study, which hopefully we'll be starting. And just to give everybody a little bit of an idea as far as the government with funding, we were getting a lot of patients who were getting letters from the government, and we were sending letters to the government to get some funding for us because we hadn't had anything. We kept getting this letter coming back from Greg Hunt and from Mark Butler. $73 million has been given to neuroendocrine cancer for research. And we thought, hang on a tick, and sort of asked all the clinicians, and we said, are you stashing this money somewhere? We found out, no, they weren't. And I actually got a spreadsheet from NH and MRC, which is one of the main bodies of it. 8.5 million was given over 10 years for neuroendocrine cancer. 60 odd million was given to neurological cancers. So it was a total misinformation, miss everything. We did get an apology, but we didn't get any money. As Kate said, we are sort of looking at, we're already recruiting into the AusNet study. And the planet, we're hoping to sort of reinvigorate and get that happening more. Education, there's some flyers over there, so if you want to take some for your GPs or any other healthcare professionals, anybody that's got an APRA, which is our registration platform, they can do it, and it's 10 CPD points, and we've had over 4,100 HCPs doing it. We did get a one-off awareness funding from the government, but that finished, it was only 1 year. We've got in-services that are online for any healthcare professionals and nurses, which Carlia does. If she's nearby, she can do it face-to-face. If not, it's all done online. We have the Living with Nets program as well, and we've got the flyers over there. We do a lot of conference presentations to get more awareness. With ComNets, we're looking at doing dietitian education modules for any healthcare professionals, and we also do these the forums. Advocacy, we've got the Optimal Care Pathway, which is a fabulous document to help with especially GPs when people have got the symptoms and patients are going in and saying, I've got this happening. It's actually got a quick reference guide for the GPs to then do the appropriate tests rather than sending you on a wild goose chase around the place. So that's on the back of the Living with Nets over there. And we do a lot of lobbying. The Senate inquiry, which was the Senate inquiry to rare diagnostic access, no, equity of access for diagnostic and treatments for rare and less common cancers, including neuroendocrine cancer, of which a lot of patients were actually asked to provide information to the Senate about, and we all presented as well down here in Melbourne. There were 41 recommendations, so we're avidly at the government to say, what are you going to do about those? So stay tuned, and if you have any MPs, we've got a letter on our website that you can send to them, and if you do have an appointment that you can see them, we're happy to join in via Zoom if we can't be there in person. As you can see, there's a lot of other things that we've been doing, and Michael spoke about belzutifan, which luckily was recommended at the last PVAC, so we're keeping our fingers crossed that that's going to happen soon. We're looking also, and was some published today in the Australian, the bridging funding, which is looking at when TGA approves a drug, that there's a bridging funding that can be available before it's put onto the PBS, so that you're not having high cost drugs. Like with belzutifan, it was costing people $12,000 a month just to have a tablet. So we're really pushing for all those things to happen. I'll keep going. And just the last thing is just to let you know with somatostatin analogues, an update. So most of you who would have been on Sandostatin LAR, eShine program closed on the 30th of April 2023. The Ipsen Assist home injection program is closing on the 31st of January 2025. If you're having any issues, just reach out to us and we can help you. And also the generic lanreotide came onto the market on the 1st of August, but they don't have a home injection program. But any issues, please just let us know and we'll work with the companies. So this one is my plagiarised combi, which Brad presented to one of the drug companies. And yeah, it's the combi van that sort of goes travelling around the countryside with its unicorn horn, and you're driving your bus. You let on who you want to let on, and don't let on who you don't want to let on. So it's your bus to drive, but we're there to help you. So thank you, and we'll do some questions now. Okay. Any questions? Okay. Who's got the microphone? This one there? Yes, please. And we've got...
Hi, thank you. Great presentations. I appreciate the importance of all the research and all the trials that are going on, but just wondered, is there anything in the delivery of lanreotide, because it is a pain in the butt?
So just let me check I've heard that correctly. So you were asking about trials in the delivery of lanreotide and octreotide. And Michael did actually refer to a trial, which is a new product called CAM 2029. That's currently undergoing clinical trial. I've had a look at it, and I'm actually a bit of a fan, so I'm really hoping that the trials are successful and it's shown to be safe and effective as the lanreotide and octreotide, because I don't know about anyone else, but I get a hot flush when I give those injections, so I've not actually stuck one of those in my leg or my bum, but they're not like tiny. The new one that's being trialled is actually a really tiny needle, like a diabetic sort of pen. It's also doesn't need to be refrigerated, so that's going to be a really good bonus for people who are travelling. And it's once every fortnight rather than once every month, but it's a tiny little needle. So we're looking forward to the results of that study, and hopefully, fingers crossed, we'll be able to do lots of lobbying with the government to fund that with the PBAC. So that's the main development that's hopefully not too far away into changing people's lives in real time. Does that answer your question?
Yes.
Great.
Meredith,
Yes.
I just wanted to say thank you for all the work that you do for us. You're just fantastic. Kate, when I first got diagnosed back in 2020, you spent an hour with my sister on the phone, helping guide me as to what choices I should make with my oncology team, and thank you. Grace, I just wanted to ask you a question. Last year, I did 4 rounds of lutate, PRRT, along with Captum, and in my head, I thought that was going to be the gold treatment for pancreatic cancer. And at the end of it, I actually got progression into the liver, and I was absolutely shocked because I just expected it to be this perfect sailing through, and I just didn't seem to win that. One of the first treatments that was offered to me early in 2024 was to go back and do lutate again, and I couldn't see the point, really. I just wanted to ask you, how often, in a situation similar to mine, how often would people choose to do lanreotide within 6 months of completing 4 rounds?
No, thank you for the question. So I just wanted to clarify, is it repeating lutate therapy 6 months after the initial treatment, or lanreotide?
Final treatment.
Yeah.
So the final treatment was in September,
Mm-hmm.
and then my options in May, June were to go back and do lutate again.
Mm-hmm.
And we ended up doing a week of external radiation on the pancreatic because they'd gone high grade, and that's when I started Botox. And there's a part of me that wonders, even by doing such big treatments one after the other, was it too much? Is that why I got going through the blood-brain barrier? Was it just too much for my system? But I just wanted to find out, how often do people repeat lutate 6 months after they've completed?
No, that's a very good question. Thank you. I guess I am only able to provide like a general, comment without specific information. It's very difficult because every individual is different. And I think the first thing to point out is that NET is actually a very, very complex disease. And the biology can be very different between different people. So some may have very slow-growing disease, some may present with more aggressive disease. But the biology also may change within the single person over time as well. So it is a very complex phenomenon, and that's why we need to have all these, tests to put together with a good team as well to guide what treatment to give at the right time. So we do have multiple options of treatment, including nuclear medicine, chemotherapy, biologic agents, but it's really trying to, find out which one to use when. It is not uncommon in our unit for people to have initial lutate therapy or PRRT, and if it was able to control the disease or make it better, when the disease gets worse again, it is certainly an option to go back to PRRT therapy. But also in that context, we will get together in a multidisciplinary setting to also discuss, is this the next right treatment, or should we try something else or something else or something else? So it is possible, definitely, to give retreatment, and in our population, I think maybe 40% may actually end up having further treatments again because it worked before. I suspect the CAPTEM chemotherapy combination was probably part of the control NETS trial, so it was probably done in a very sort of careful, scenario. But I guess the main answer to your question about retreatment is that, yes, it can be done, but it has to be assessed on the individual basis.
Just a question for Cherie, just about I've got lots of questions, but narrow it to one. With the WE test, what's the recommendation for how often it should be done, and can tumours transition from being non-secreting to secreting?
Both. They're both very good questions. I'll answer the second question first. It can. So we've certainly had NET that switched from non-functional to functional. So I think NET is in the space where we say never, never. We never say is always going to stay as it is. Your first question is really at the time of diagnosis. So once there is a tissue diagnosis of NET, you might have noticed the slide I've shown. There are a lot of hormones that's possible, but we don't test for all of them. So the oncology team assess the patient, asks a set of questions in terms of what hormones you're likely to be secreting to cause the symptoms. So if you fulfill all the tick boxes in that banner, then definitely they would be looking for carcinoid, and that would be the WE test or the urine 5-HIAA. So that's done at diagnosis. It's important to diagnose so that these symptoms can be treated. And also, if at diagnosis you're about to have surgery, it's also important to know, well, how high is the tumour load, how much are you secreting, so that they can cater for that for surgery. And then thereafter, like all biomarker or tumour markers, is used as a monitoring prognostic therapy along with imaging. So we look at the imaging, we look at the biomarkers, and generally they will go down or respond in parallel.
Hello. I've been around a fair while, and for a really, really long time I couldn't have PRRT because I have kidney disease as well. I'm now a dialysis patient. Does that allow me to now have PRRT? Because my kidneys don't work already now.
Thank you for the very tricky question. But it's a very valid question, though. I guess there are two components to it. The timing of PRRT. So we do have, criterias. Not everyone with a NET, with the target, should get PRRT. So there are different scenarios where we would assess whether it's the right time for someone to start PRRT. And usually the right time would be, if you've had a NET for a long time, is if the NET is growing, despite conventional therapies, usually the standard analog injections. So if it's growing despite conventional treatment, or if you're very symptomatic with lots of hormones being produced, then in general, PRRT or other active treatments should be considered. So timing is the first question. So if you're well and the tumour's not doing anything, then I think watch and wait is not unreasonable. The second question is, if you do need to have treatment, is dialysis contraindicated? I think we need to consider it very cautiously. I wouldn't, like Cherie, say definite no. It really depends on your tumour load, the indication of why we're giving you PRRT. And we actually have treated someone before, but it has to be decided with informed consent. Because it is a complicated process. The radiation, one logistics is the radiation will circulate, it will end up in the dialysis machine. Whether it's peritoneal or dialysis machine, we have to look after the radiation side of things. But also, with the radiation doses, we may need to adjust how much we give. So if you need it, happy to have that discussion, if you want it. Yeah.
There was one question that came through that I'll just read, but any other questions that we had sent through to us, we'll answer them separately by email. But over the last few decades, there's been a significant increase in the reported prevalence of most NET types. Apart from improvements in diagnosis, are there any lifestyle factors that might be contributing to this trend? That could be any one of you that could answer that.
Lifestyle. So, that question is really asking, are there any environmental factors that increases NET specifically? I'm not aware of any. There's certainly genetic factors. Mm-hmm. There's certain NET that is inherited as part of a mutation syndrome, but I'm not aware of environmental factors that's specific to NET that's preventable.
What would those genetic factors be?
So there is MEN or multiple endocrine neoplasia. We call it MEN1, and they're prone to pancreatic NET. There's also MEN2, and they're prone to pheochromocytoma. So there's actually a very extensive genetic panel for things like paraganglioma, nothing that's specific to carcinoid that I spoke about today. But whenever we come across a tumour like a pheochromocytoma, automatically in Peter Mac, they'll undergo genetic study.
Any other? Yes?
I've got one. Alternative medicines or practices that can be integrated into our treatment programs. I was wondering whether that's being looked at as a more holistic approach.
It's a good question. So I don't know if everyone heard. It was around the integration of integrated therapies, I guess, might be a way of capturing it. I think it's really important to differentiate between complementary therapies and alternative therapies. So complementary therapies are designed to go alongside your cancer treatments to help you feel better. Alternative therapies are therapies that people might choose instead of standard cancer therapy. So they do need to be differentiated quite sort of carefully so that we're talking about the right thing. So in terms of complementary therapies, so they're all of the things, the supportive care kind of things actually that we really benefit from our multidisciplinary team to help deliver. So things like our psychosocial care, our music therapy, our exercise physiology, our dietetics, they're all therapies that are designed to help people live better while they're having the treatment to shrink tumours, because if we just do the treatment that shrinks tumours, people often feel pretty rubbish. Sorry, Grace. So there is a lot around that. I think that one of the challenges in a publicly funded service is that every penny is turned over 3 times before it gets spent. So integrating a lot of those kinds of really important therapies sometimes it's really challenging for services to provide. And as I said in Peter Mac, I feel very lucky to be part of such a comprehensive multidisciplinary team. But I know actually we're really spoiled here, having worked at NECA for many years and heard so many stories of people where there's not a nurse or there's not a NET dietitian or there's not, any of those other kind of wraparound services. And so I do acknowledge that for a lot of people out there living in the real world, it is around working out who you're going to have on your bus, and that takes a lot of research, and it's also really tricky when there's lots of different voices telling you, oh, take this vitamin, take that mineral, I've heard about this other thing, why don't you try that? And so I think it's a complicated decision-making process. It can be difficult to know from a lay perspective whether something is safe and whether something will sit well with your standard therapy. We know that some things like vitamins and that sort of thing can actually dance very badly with our standard treatments. So I guess our advice would be to always run it past your treatment team, especially if it's something that you're ingesting, to make sure it's safe and it's going to dance well with what we're doing. And also I would really recommend you contact Neuroendocrine Cancer Australia for guidance around, they'll be able to help provide some of that evidence and that initial guidance around the use of some of those things. But the other thing I would just mention is the Cancer Council have a really fabulous, really comprehensive booklet around the use of complementary therapies and how to evaluate those choices and that information. So 2 really good resources. There might be other additions.
Lovely. Well, I think it's nearly 8:15, and I think it's been a really informative. Can you make a comment?
I'm being really cheeky, but I've known Meredith for a really long time, and I'll suffer the consequences. I heard there were some earlier questions to Michael, and unfortunately he needed to leave, about getting a second opinion at Peter MacCallum, and I thought I did have some comments to make in addition to what Michael said. It really endorsed what he said about it being your right to seek a second opinion, but also really acknowledge how awkward that can feel when you're like, I don't want my oncologist to think I don't like them anymore, or I don't trust them. So it can be a really sticky kind of emotional position to be in. I would encourage you, like Michael said, to have that conversation. And what I've always said to people is, if your oncologist is getting shirty and edgy about you having an opinion from another service, that says a bit about, maybe, I don't know, I'm saying this publicly, and so, but I think sometimes we get a bit edgy and nervous when we've got a bit of a fragile ego, maybe, but also I think really mainstream, multidisciplinary, major services welcome a request for a second opinion. Our patients ask for second opinions with other services, and we're only too happy to write that letter, because I think the more people who sometimes, especially if it's a really tricky, rare kind of subset of NET, we want to get all of the brains in on the job, and it's really great to have the opinion of your current oncologist endorsed and said, yep, we would do exactly the same thing as what you're on. It's really confidence inspiring. So I would encourage you to have the conversation with your oncologist. From a funding point of view, from a Medicare point of view, it is possible to get a referral from a GP to Peter Mac, but I can tell you, as the person who triages all of the medical oncology referrals to Peter Mac, there's very few GP referrals that are comprehensive enough for us to be able to really evaluate the treatment that people are on when we get those referrals. So the vast majority of GP referrals we do need to decline because we don't get enough information to be able to tell whether or not you're on the right treatment, and we don't have enough background about your cancer to make that kind of choice. So it is actually much better if it comes from your treating medical oncologist or the person who's managing your care. So I just wanted to encourage you, though, to have that conversation, because the other awkward thing that can come from a GP second opinion referral is if we do get all of that information and we do see you and tell you about what we would be doing, you've still got to have a conversation with your treating medical oncologist about, well, I've got to kind of, you're trying to make that decision. So that's just my, sorry.
No, that's okay.
Trying to be brief, and I know someone's got their hand up. Maybe we can talk about it afterwards.
I was just going to say, as far as that goes, with other centres around Australia, with the NET centres, they don't mind having a second opinion, and most of the oncologists that I know, they are happy to look at the case, recommend a management plan, liaise with the local doctor, medical oncologist, so that the treatment can be given at home, not to transfer the care to the big metropolitan. And I think with the ego sort of statement and everything, I think it's a lot of them frightened that they're going to lose their patient to the metropolitan centre, whereas the metropolitan NET specialists, they don't want to do that. They want to be part of the management and advise what would be the best care, and then have that in their own location, unless it's for PRT, but you can't sort of do that.
Yeah, it doesn't really make sense to drive past 3 hospitals to get to Peter Mac or Royal North Shore or whatever if you're going to get exactly the same care at the hospital that's closer to you, so that if you're sick, then you go to, that's much closer to home. Things that would I guess suggest that a second opinion referral might be advised are if your cancer's kind of changing and not responding to the treatment, and the team's scratching their head, I think that's a really important thing to advocate for yourself. Or if your symptoms are particularly sticky and tricky and we're having trouble getting on top of those, that's another indication that perhaps getting more brains in on the story might be helpful. But yeah, NECA will be really helpful as well in terms of helping to work out whether or not that's important. There's so many, like we've got, 25,000 people in Australia with NETs.
Nearly 30,000
Nearly 30,000 people
Yep.
in Australia with NETs. So obviously Peter Mac can't treat them all. We've got a couple of thousand patients on our books. But so many people actually have really, really beautifully, appropriately cared for treatment. They're beautifully cared for with their current treating team. So yes, have the conversation.
So
Grace, you
do
look
we
like
have one last? And Grace, did you want to say something?
Sorry.
No? Nope. Okay. I won't force you to. Okay. Well, thank you so much, everybody, for coming along. It was great to see you all. And we're here. Peter Mac's here. We all work together. And if there's anything that you need, please just reach out. So travel home safely and have a nice... Thank you.